My name's Jane MEARS, and I'm the chair of this session, which is about interdisciplinary approaches to living well with dementia, a critical dialogue. And we're hoping that that is what it will be, a dialogue between you people who are watching, of course, this session, and us. We've done quite a lot of work together, as you'll see, trying to bring this all into one presentation. So I'll introduce, I won't waste any more time, of course, but introduce our first speaker, and that is Sachin Matthews. Sachin is an international student enrolled in the Bachelor of Social Work qualifying at the University of Western Sydney, and Sachin is doing a placement with us at Dementia Australia. Sorry, Dementia Reframed. That was a really bad slip. Sachin, as you'll see from this presentation, is an excellent student and has gone far beyond what one would expect of a student on placement. And he is presenting this wonderful paper on untold stories, the impact and consequences of COVID-19 on people living with dementia in Australian residential care systems. You can see his head shaved in the photograph. I think we'll find that when he comes in person, he may well have hair, so you'll recognise him. Sachin, I'm delighted that you can do this presentation, and also so thrilled at the amount of work you've done. And as you well know, I've thoroughly enjoyed our conversations in developing this paper on the impacts and consequences of COVID-19 on people living with dementia in Australian residential and home care systems. So over to you. Thank you very much.
Untold stories of the impact of COVID-19 on people with dementia in residential aged care and home care within Australia. The concern stares at coughing passerbys and mandatory face masks in public transportation are some of the remnants of COVID-19 related lockdowns that took place in the Australian state of New South Wales in 2021. With the current estimated death toll and case numbers being at 7,163 and 332,239 respectively as of the 29th of April 2022, the COVID-19 variants and subvariants of concern are still prevalent and spreading quickly, particularly affecting older people, people with disabilities, and those with compromised immune systems. The primary focus of this paper is to analyze the impact of COVID-19 on the aged care system within Australia, with particular attention given to the problems and barriers faced by those living with dementia in residential aged care, home care, and those living within the community. The COVID-19 was declared an official pandemic by the World Health Organization in early March 2020, with more than 4,000 deaths and over 118,000 people infected worldwide at the time. By March 2021, this had progressed to 3 million deaths and 146 million cases. Comparatively, at this time within Australia, there were 910 deaths out of the 29,666 people infected. This success was attributed to the coalition federal government's initial response to ensure zero spread by closing the borders and using quarantine measures to keep the virus out of Australia. Testing, tracing, isolating, while also pledging to vaccinate the population, giving priority to the most vulnerable, older people, those in RACs with disabilities and compromised immune systems, and Indigenous Australians. The regulatory authority in charge of accreditation for aged care homes within Australia is the Aged Care Quality and Safety Commission, which conducts periodic audits to assess an aged care home's service provision against the legislated aged care quality standards. In 2021, an Aged Care Royal Commission report into aged care quality and services found that the Aged Care Regulatory Authority currently only assesses providers on a binary met or not bet basis, not allowing for meaningful comparison of different services and failing to provide the extent by which care exceeds or fails the minimum standard required. During the pandemic, lapses in oversight by the Aged Care Quality and Safety Commission can be seen, as 817 homes had their audits postponed, with site visits decreasing from 3,452 visits between January 2020 to 2021 to only 654 visits between January 2021 to 2022, with one such home that had its accreditation extended being recently sanctioned by the regulators for infection control lapses and failure to prepare for staff shortages. The federal coalition government currently treats each RAC on an individualized business model, giving private providers free rein over keeping their RAC safe. This has resulted in inconsistent policies around visits and staffing, as profits are often prioritized over care, leading to differences in care provided by the for-profit and state-run care institutions. For example, in Victoria, privately run aged care homes often have a single registered nurse rostered on to look after 100 residents, while in state-run care homes, which operate under the Safe Patient Care Act, ratios of registered nurses are prescribed during each shift, such as in the mornings, one is required for every 7 residents, in the afternoons, it's one for every 18, and during nights is one for every 15. This disparity between private and state-run homes can be seen as out of the 46 deaths that happened in Victoria's aged care homes till the 31st of Jan 2022, 42 of them were exclusively in privately run homes. This disparity is even wider in New South Wales with the coalition government where currently there are no staffing ratios within the aged care sector. With staffing vulnerabilities and the promise of vaccination program being spectacularly unsuccessful, resulting in very low vaccination rates in RACs, 7% or 2,051 of all 29,666 COVID-19 cases that occurred in 2021 happened within RACs. Within deaths in RACs accounting for 75% of all COVID-19 related deaths. That is 685 out of the 910 deaths. Furthermore, between the 7th to the 21st of January 2022, when the Omicron variant was running rampant due to state border relaxations by the Morrison and the Patriot governments, 703 care homes recorded new outbreaks and 105 saw a surge in numbers, resulting in the implementation of lockdowns within these homes. This resulted in worsened outcomes as many aged care homes within Australia are not designed to cope with an airborne virus, with many homes not being able to open windows in residents' rooms, hindering proper ventilation and enabling the virus to spread rampantly. Adding to this, as case numbers rose, personal protective equipment and rapid antigen tests and surge workers promised by the federal government were nowhere to be seen, forcing nursing managers in these homes to stretch their limited resources during times of uncertainty. The result of which was RACs having to rely on workers with no prior training during the most recent Omicron wave, resulting in worsened care outcomes. For example, Jess, a lifestyle worker whose initial role was to facilitate outings and activities for residents in a privately run aged care home, during the pandemic, was asked to work the floor, helping with caring, feeding, and bathing the residents due to staff shortages, regardless of her not having any training as a care worker. Just recalls a moment where a woman with severe dementia was on the floor, lying in her own urine and feces, unable to get up. She tried to get 2 nurses as 2 are required to operate the hoist machine in order to lift the resident, but there were only 2 on duty that day, leaving the resident essentially sitting in her own excrements. In 2020, a study conducted looking at the impact of poor social networks on 464 participants with dementia. Poorer social networks were significantly associated with a greater likelihood of dementia severity, meaning poorer social networks were associated with a greater likelihood of these individuals experiencing serious adverse effects in the long run. A more recent study conducted using qualitative peer-reviewed findings to look into the effects of isolation measures during COVID-19 on cognitive, psychological, and functional symptoms of people with any kind of dementia or mild cognitive impairment, found that out of total 6,442 participants with dementia, 60% reported changes in cognition, with 77% of them reporting a decline in cognition by lesser than 50%. Furthermore, 93% of the total study reported a worsening or new onset of behavior and psychological symptoms, while 46% reported changes in daily function. Real-life examples of these findings can be seen through the personal accounts of those with dementia within residential aged care homes impacted by lockdowns conveyed by their families and carers. Ian was diagnosed with Lewy body dementia, which is characterized by the onset of delusions and hallucinations, and moved into care after he was unable to perform everyday tasks. During South Australia's initial lockdown for 3 to 4 days, Claire, his partner, was unable to meet Ian, and upon their later interaction, Claire had noticed a deterioration in his speech and his ability to walk. Vivian Russell, a mother in her 70s with early onset dementia, had undergone a 6-week lockdown in her aged care home due to a surge in coronavirus cases within the community. Her daughter, Verity, recalls receiving calls from the care home where her mother insisted that she wanted to come back home, claiming that she didn't want to be there anymore, further stating that her mother was so starved of touch and stimulation that she would be crying and became incredibly depressed. When Verity was finally able to meet her mother, she noticed that her mother was shuffling instead of walking, was unable to follow instructions, and had difficulty in grooming herself as well. The most recent wave of the Omicron pandemic exacerbated conditions in an already exhausted system, leading to an even worsened impact within residential aged care homes, as seen through Katerina, a 94-year-old living with dementia residing in an aged care home in the southeast of Melbourne. She has endured 2 lockdowns in the start of December 2021, during which time she has spent 10 days entirely confined to her room due to COVID-19 outbreaks. Her daughter Lisa recalls day 1 of her mother's isolation being the most horrific, as she had received around 15 calls from Katerina, pleading with Lisa to explain what had happened, as she was unaware of what was going on around her, further stating that her mother was deteriorating and that she could hear her mother's voice weakening through the phone. In Australia, in the current neoliberal economy, the free market is king. This results in aged care providers following individualized business models which prioritize stakeholder profits over the quality of care received by the residents within these homes. Though an increase in staffing would help relieve some of the burden felt by the current aged care system, it is only a short-term fix if the policies in place do not value the rights of those individuals within these homes. This requires both a restructuring within the sector and a reframing of the mentality that care is a commodity to be bought and sold, viewing it as a right of every individual. In doing so, compassionate, flexible, and relationship-based care can be prioritized, which maximize care outcomes received by those individuals within these homes living with dementia and respects the rights and wishes of their families and carers. Thank you.
Our next presenter is our wonderful colleague, Lucie Downer. Lucie is a student at the University of Sydney, and she's been working as a volunteer with us at Dementia Reframed for the last, I think, probably at least 3 years. She is an amazing young woman, and again, her work with us has been absolutely phenomenal. Again, like Sachin, far more than one would expect of a student. When she first started working with us, she was an undergraduate student. She's now doing her postgraduate degree and is hoping, of course, to go on to a PhD, and we're hoping that she will too. The area that she's looking at, which follows on, as I say, from Sachin's paper, which tells us about what is happening to people with dementia in residential care. She's focused in on the geriatricians and their role as I guess, gatekeepers on the front line in combating dementia. And she's going to examine how this works or indeed doesn't work in Australia. And again, as with Sachin's paper, the sorts of research gaps that Lucie's exploring here have been very much exacerbated by the COVID pandemic, and she has taken that into account in her paper, of course. Lucie, thank you so much for presenting with us this afternoon, and I'm absolutely delighted again by the amount of work that you put into this paper, and I'm really impressed by what you've produced. So welcome, Lucie.
Throughout Australia, people diagnosed with dementia experience high levels of stigma. This stigma has negative consequences. They are disregarded and neglected. Their capacity to live well throughout the progression of the disease is greatly underestimated. This experience of stigma is well researched. However, my interest is in the source of this stigmatizing. One source, I argue, lies in the ways medical professionals approach dementia. It is defined as an incurable disease still impervious to pharmacological treatment. Emphasizing that dementia is a disease rather than a mental illness has been thought to be important in countering fear and stigma. However, when the disease is incurable, as well as progressively debilitating, there is an absence of hope that is normally associated with being able to recover or be treated. This framing undermines the idea that it is possible to live well with a neurodegenerative disease. In turn, albeit unwillingly, this reinforces stigma. Diagnosis is normally conducted by geriatricians. However, living well with dementia is not a medical problem. It is a social problem. Dementia's impacts are social. It affects communication and relationships. Unless geriatricians work with an interdisciplinary team, they will find it difficult to help a patient focus on living well. This is not their training. And yet there are many people in Australia who report that their doctors simply tell them there is nothing that can be done. My paper challenges geriatricians to work on a new model for thinking about and valuing life with dementia. Stigma is the negative labeling, separating, discriminating, and stereotyping of a person who holds an undesirable characteristic. Stigmatizing is facilitated through systems of unequal power that develop between us versus them, with the dominant group seeking an identified difference in the other group as undesirable, even threatening. These undesirable characteristics are contextually variable, but the results of the feelings, beliefs, and behaviors that do not conform to the norm. Those attributed with the characteristics experience a loss of status and value. Dementia can lead to behaviors that are considered inappropriate in the public or that disturb those who accompany or care for. This might include, for example, an increase in the use of swear words, not being able to hold a conversation or answer a simple question, forgetting appointments, and becoming agitated because of the reactions of others. In some cases, there are hallucinations which cause distress when they are denied. Not only the person living with dementia, but also their care partners find themselves the subject of stigma. Negative effects including feeling discriminated, poor mental health, low self-esteem, and isolation, resulting in a decrease in quality of life. Clearly, this is not living well and can often compound the progression of dementia and stress of carers. The experience of people with dementia being stigmatized has a long history. However, given the current and well-founded concern concern with helping people to live well, understanding its sources so as to alleviate the negativity this produces is important. The biomedical framing of dementia as a disease rather than, for example, normal aging or madness has not, as was expected, reduced stigma. Stigmatizing language and attitudes are still evident, and especially, if not surprising, among healthcare practitioners. This includes GPs not taking the time to get a proper diagnosis, or doctors assuming that, given the diagnosis, that person's life is effectively over. Fear and intolerance can be reflected in the language of healthcare professionals who refer to a tragic disease as someone not old there, demented, the living dead, or as regressing to childhood. This language devalues, decredits, and invalidates people with dementia. It limits their lives and limits their care options. As the cure remains elusive, The result can be therapeutic nihilism, the perception that nothing can be done, so nothing is done. To understand the ideas and practices that stigmatize, we need to identify the ways in which the stigmatizer imagines their own self such that they create a negative other. In this context, what cultural and social forces produce and legitimize the stigmatizing ideas held by medical professionals? Imagining oneself is integral to imagining of another. To keep the image of a competent, self-aware, and successful self thus requires a refutation of all that seems to permeate what are actually the fragile boundaries of this self. In turn, this leads to denial and fear and the rejection of the other who represents what one does not want to become. Clearly, it is important to understand how the stigmatizer is imagining themselves and what social attitudes influence this. Today, neoliberal, economically oriented understandings of ourselves emphasize individualism and independence, rationality and sharpness of thought as being essential to social worth and success. One's value lies in what you can do rather than what you are. Impairments resulting from the process of neurodegeneration conflicts with these central values of our culture. Thus, dementia is seen as a threat to the person. They are described as losing their personhood. Their identity is despoiled, and they are no longer considered fully human. Stigma is thus a processing of other that reaffirms the dominant social values while undermining those who don't hold them. This indicates, especially in the context of the doctor-patient relationship, which is already unequal in most social contexts. The attitudes of the doctors will have a crucial effect on the patient's self-image. If the doctor sees the patient as incurable and beyond hope, this will not encourage the patient to feel he can live well despite diminishing abilities. When human value and potential rests on reasoning and rational cognitive abilities, this then justifies the neglect of people with dementia, resulting in the pernicious idea that people with dementia don't just change, they lose their personhood. This is illustrated, for example, in the representation of people with dementia, with images depicting fading or disintegration. This conception of dementia places the person with dementia in a world that deliberately, if not unwittingly, devalues and segregates them. Dementia is not just a disease. It is also a way of thinking about a person with that disease, an experience through which that person can either be nurtured or diminished. We need a society that is equipped with the knowledge of how to meaningfully incorporate people with dementia. This requires us to move beyond the biomedical understanding of dementia. As Makaika argues, dementia is always a relationship between the person with dementia and those who support them. People with dementia need those social relationships to live well. Others need the support to adjust their own forms of sociality as the brain changes progress. These ideas are not new. Kitwood was writing similar things nearly three decades ago, but we still haven't made much progress because the medical model of dementia as a brain degeneration and loss takes inadequate account of the complexities of humanness and the role of, for example, body memory, intercorporeality, and all the relationships that maintain the self. Vast stores of implicit memory remain unimpaired even into the late stages of disease. Personhood develops in the interaction between the brain, body, and the social and material environments that form conscious experience. Dementia will impact on these interactions and thus on consciousness, but not in any consistent or predictable way. For example, procedural memory of tasks can be retained long after the name of the objects used or forgotten. What is seldom, if ever, lost is the capacity to recognize another human being, even if they cannot be named, including sensing whether they are empathetic or hostile. The idea that increasing awareness of dementia as a disease will reduce stigma is only an assumption. There needs to be an increased awareness through a model of care that focuses on the capacities that are attained on the one hand and the importance of relationships to enable anyone to live well. Dementia challenges us to find a new way of connecting to people who find it hard to connect. Positive interventions and enablement need to be the focus, not loss, neglect, and isolation. There's ample evidence that good relationships are what helps people live well. For this reason, changing negative and stigmatizing social attitudes is essential to the well-being of every person with dementia. And this also means those who care for them. I'm suggesting we need to make room for those characteristics and ways of being human that we are being made to see as undesirable symptoms of dementia. People with dementia will live well through our reshaping of the social body. We now have dementia-friendly communities, dementia villages, and Alzheimer choirs, but we need more. We need societies in which people with dementia feel accepted and safe, not isolated from them. We need to move beyond the medical individualizing model of patient with disease to focus on living well. And this is where an interdisciplinary care team, which includes family members, are essential. Post-diagnostic pathways need to be social, not just clinical. I return to the importance of medical professionals in facilitating the incorporation of the dementia other into the us. Medical models of dementia have clout in the social, cultural, economic, and political spheres of Australia. The stigma perpetuated by medical professionals limits development of non-medical approaches to care. Good communicative, relationally based care training should be mandatory. Kitwood demonstrated that some of the deterioration seen in people with dementia was caused not by the disease itself, but by how people were treated. What he called malignant social psychology stemmed from relationships which devalue, dehumanize, and diminish the person with dementia. And this is why we need the influence of that prestigious and influential medical professionals can bring to this space by demanding humanizing interdisciplinary teams to be formed around every person and family impacted by dementia. We want caring medical professionals to demand that their patients receive much better post-diagnostic care, even if they will not be delivering much of this themselves. Demand that your patients have a right to live well. Demand the social services they need to do so. Thank you.
The third paper is from Jen VANERIS, and it's also, it was started by Maisha Ela of the University of Western Sydney. Western Sydney University. And it is called What to Look For in Developing Best Practice in Dementia Care, and follows on from the first two papers in that it offers a critique of the gaps that Sachin and Lucie have discovered, and how indeed we deal with those gaps, how we develop and implement best practice in dementia care in Australia. As you would be aware, it's like every country across the globe, we don't do any of this very well. We have often very fine motherhood statements coming from the top, but very little research on what is going on within the community and what people like Gaynor, all five of us, six of us, working with Dementia Reframed, are trying to do in terms of meeting the needs of carers of people with dementia in Australia. Again, this has been exacerbated by COVID and is very much on the political agenda at this time. So Jen is looking at, as I say, what to look for in developing best practice in dementia care. Jen is at the moment an undergraduate student. She was in one of my units this time last year and wanted to do some voluntary work with us to build up her research skills. And this is the result of what she's done so far. She took over from Maisha Ela, who worked with us on a placement in 2020, and she started developing this paper, What to Look For in Developing Best Practice. And indeed, much of the initial groundwork, most of it really, has been done by Maisha. Maisha has now graduated and she's looking for a job. And she thoroughly enjoyed her time with us at Dementia Reframed and certainly developed, as you'll see from this paper, excellent research skills and certainly her critical thinking, I might add with a lot of input from Gaynor in particular, and her skills in terms of arguing her case became very well developed. And as I say, you'll see that from this paper. So this paper is by Jen VANERIS with Maisha Ela, What to Look For in Developing Best Practice in Dementia Care. Good afternoon, everybody. Welcome to this session. I'm Jane MEARS. As you already know, I've already introduced myself. Unfortunately, Jen and Maisha are unable to present the paper today. So I'm going to very quickly give you a very short summary of the paper that they have written for me. Gaynor, of course, will take that up in the discussion next. So what the paper is titled, What to Look For in Developing Best Practice in Dementia Care. What Jen and Maisha did was a very, very careful framing, scoping and review of the literature about what constitutes best practice in the context of dementia care. What they found was that in Australia, there are very few research or evidence-based practices to assist us to establish standards and guidelines. We found that, for example, there are very few referral pathways to which professionals can refer people with dementia, let alone referrals or places for those caring for those with dementia to go to get support. Further, there's little consistency in the models of care underpinning professional practice, and it's often hard to identify where professionals are coming from in relationship to the advice that they're giving and what sort of account is being taken of the person with dementia, and more particularly in regard to their carers. And lastly, we have no national standards in Australia in regard to the training of care workers. The training provided by aged care providers is frequently contracted out and is varying and is often of questionable quality. And there are very few programs training professionals across the health and social care spectrum, looking specifically at dementia care, and most importantly in our case, looking at the sorts of advice and support that is offered to carers of those with dementia. Unfortunately, it's very hard to work out what's going on in our system because providers are not accountable, responsible for a lot of the care that is given to people with dementia in residential care and indeed in home care, as you've heard from the previous papers, which leaves residents and families having to take on responsibility for this care. And indeed, when things go wrong, it is the families and carers that are seen as the ones at fault, not the system. The system is totally risk averse and does everything it can to silence complaints and not listen to the voices of either carers or those with dementia. Further, there's little transparency, so it's very difficult to understand and evaluate what is happening across the sector. It's difficult to make international comparisons because we're reliant, we don't have the data that is to assist us to understand the most pressing area in terms of reform in Australia. We're reliant on much secondary data. Much of this was documented in the Aged Care Royal Commission, and on thousands of stories from those with dementia and their carers about their experiences with residential aged care and home care. And indeed, for the past 5 years, Gaynor and I have been very, very aware of the many, many stories. We have been actually for decades, but particularly once we started looking at those caring for dementia care, and there's a huge gap in service provision. So the scoping review demonstrated that models of care developed explicitly for people with dementia reveal that there were 3 distinct orientations. First, a focus on changing the behaviour of the person with dementia. Secondly, a focus on the changes required on the parts of partners. And thirdly, a focus on changing the living environment. So none of these take into account the professionals providing care, or indeed the nature of the care that's being provided. And it's a focus simply on the things that you can see, the structural things that you can document in a ticker box checklist. And indeed, the system is absolutely wrought full of incredible forms for you to fill in. For example, to get into the system, to get on a waiting list, which is usually, I think it's around about 100,000 people, one has to pass through the My Aged Care gateway and register. So even before you can get an assessment, you have to fill in a 20-page form, which is extremely complicated and almost impossible to fill in either online or even if you have somebody helping you. It's a really grueling business. So what we are arguing is that listening to carers is essential, and it improves the quality of life, it improves the way people relate to each other, and this has major implications for staff training, and most importantly, the engagement of family members in care roles and the way that we go about doing this. Maisha and Jen pulled out examined some sample models of care used in Australia. They looked at the butterfly, the Montessori, and the positive approach to care. The PAC method uses a progressive brain change model to enable care partners to respond informatively to the ways in which brain changes affect communicative, sensory, and skills abilities over time. We argue that this model stands out for its interdisciplinary approach and provides a benchmark from which we can assess other models. The PAC program, as I say, is a relationship-based model established by Teepa Snow, and the PAC method is unique and recognises the relationship between brain changes through the different stages of dementia and how a person responds. I'll let Gaynor talk a little bit more about that in her summing up, but just to sum up this particular paper, what we have done is identified through this review that Jen and Maisha have assisted us with, a clear gap in the offerings of the My Aged Care program, and indeed aged care, the aged care system in Australia overall. We have identified a clear gap in offerings, in the support offered and the care services available to those with dementia and their families. Indeed, we have found that the PAC approach is far more adaptable and realistic, and takes a whole of society view and takes into account differences, social inequalities, and builds relationship-based, consistent and flexible care for those working with those with dementia. We have been at Dementia Reframed working very successfully for the past 5 years, raising attitudes, talking to people about reframing our approaches to dementia, and we're in the process of collecting more evidence and conducting evaluations of the work and the workshops that we are doing. So watch this space. I think this is such an important area of research, and I know from the feedback we get from those caring for dementia that they also find the work that Gaynor's doing extremely useful, very liberating, and extremely empowering. Thank you very much. Now over to you, Gaynor, for the summing up of this wonderful session. Gaynor will sum up, and as Michaela said at the beginning, we will then take questions from the audience. Thank you all very much for listening, very much appreciated, and I look forward to fielding your questions. The fourth presentation today is from my much esteemed and much loved colleague, Dr. Gaynor MacDonald. Indeed, she is the driving force behind Dementia Reframed, keeps us all well and truly on track, and keeps us thinking about absolutely everything. You can imagine the sorts of conversations that we have together when you look at the quality of the papers that my three colleagues have presented already. Gaynor Gaynor and I were both, I was a lecturer, professor at the University of Western Sydney, and Gaynor in social policy, specialty aged care. Gaynor worked at University of Sydney as an anthropologist. We have both we're both now working full-time on the Dementia Reframed project, and our university work, of course, we still do, but we're no longer employed full-time or paid by the university. So Gaynor is going to look at interdisciplinary approaches to living well with dementia, a critical dialogue. And she's going to pull together the papers that have already been presented by Sachin, Lucie, and Jen, and help to make sense of them, and indeed bring the things together in a way that makes sense to us and shifts us into an area where we can think critically about the sorts of our attitudes towards dementia, the sorts of things that we're offering in terms of support, and how appropriate and inappropriate these are. So Gaynor, over to you now, and thank you very much for all your work for Dementia Reframed, and of course today for pulling together the remarkable work that has been done by our four students in this context. So over to you, Gaynor.
Recently reading about Australian research designed to develop clinical pathways to provide consistency in dementia care, I was concerned that these will be informed by what is known as the BPSD model, the behavioural and psychological symptoms of dementia. There is no doubt that, as VANERIS has pointed out, Australia has no clear pathways for the delivery of dementia care and no agreed upon standards or criteria upon which these might be based. Yet BPSD is a distorted model upon which to base dementia care, despite it having been influential for decades. It's over 10 years since Dupuy and colleagues showed how deficit and problem-based approaches to behaviour stigmatise persons with dementia. They cause unnecessary and great suffering. Arguing that biomedical discourse emphasises these negatives, they called for alternative discourses that emphasised meanings of actions using multidimensional lenses. Behaviours associated with dementia become pathologized and problematized, particularly in the long-term care context, as well as illustrated in Wallace's detailed account of her husband's treatment in residential care. Not only was he pathologized, it was evident that most of what was defined as his so-called difficult behavior was due to either inappropriate medication or inadequately trained staff. The point is, it was not due to the fact that he had Lewy body dementia. Downer's presentation examines the ways medical professions have been co-opted into this stigmatizing approach. The BPSD model asserts that what are called challenging or difficult behaviors are symptoms of dementia, although there is no evidence that these are caused by neurodegeneration. The processes of neurodegeneration are becoming much better understood, as are the specific forms of cognitive and physical loss they generate over time. However, a great leap is then made between this biomedical knowledge and the assumption that these changes cause unwanted, undesirable, challenging, or difficult, you can choose your adjective, behavioral and psychological changes. Aggression, for instance, is called a symptom of dementia. Many people experiencing dementia do get aggressive, but why? Brain degeneration causes a decline, often quite rapid, in peripheral vision. A person may still be able to see clearly, but with increasingly limited range. This loss of peripheral vision is a symptom of neurodegeneration. Now let's look at the effect of that on somebody becoming aggressive. A caregiver unaware of this limited vision will often use inappropriate methods of approaching and working with the person they're caring for. If they approach them from the side or the back, assuming that person is aware of their presence and entering their personal space, they may startle or alarm them, and that person may lash out at the unexpected intrusion. Their amygdala is undoubtedly healthier than their visual cortex. Punching that intrusive person is an understandable reaction to a threat, as is shouting at them, or more mildly, getting agitated and uncooperative. But the punching, shouting, agitation, and lack of cooperation are not symptoms of dementia. They are symptoms of poor communication, almost always occasioned by a poorly trained care partner, one who is unaware of the need to change their own behavior to respond well to the changes that dementia is causing. Aggression is a symptom of relationship, not of dementia. My general point is evident in the 3 papers we've listened to. Excellent dementia care is available. It is marked, as Jen VANERIS has shown, by 3 characteristics. A strong understanding of brain changes, where in the brain these take place, how advanced the degeneration is, and the impact this has on a person's executive function, perception, and skills. Secondly, an understanding of how to gauge the state that a person is in at any given time so that the care partner can assess their ability and respond accordingly. And thirdly, the care partner has to be trained to respond well so that they know how to approach, speak, calm, engage, deflect, de-escalate, or whatever else is called for to keep that person safe and well and engaged. The BPSD model, therefore, acts as a disincentive to learning about and valuing social, communicative, relationally based care. This, as Downer has argued, contributes to fear and stigma. The idea that fear stems from a lack of understanding that dementia is a disease is inadequate. It stems from the despair and confusion generated when a doctor says there is nothing that can be done. And this is not good enough. The pathways required are social, not clinical, at least not now or for the foreseeable future. Geriatricians and general practitioners on the front line need to reframe their fear-inducing, biomedically limited approach and work closely with people who can offer good relationship-based care. Matthew's paper shows the dreadful effects a biomedical approach can have when the social imperatives of life with dementia, even with dementia, are discounted. When care systems reduce health to physical health, denying the equally important value of social health, they hasten death. The pandemic was incredibly challenging, but too many people with dementia died of isolation and neglect, not COVID, as strategies to contain the virus exacerbated the progression of the dementia. Containing a deadly infection cannot be at the expense of social engagement. Dementia care does not need clinical pathways. It needs relationally based care that is informed by the medical knowledge of what is happening in the brain. Dementia highlights the need to bring first-class medicine together with first-class relationship, balancing biomedical and social well-being. This is not optional. It is what life is and has always been about. The distorting BPS model of dementia is preventing good dementia care. Care requires an holistic and interdisciplinary approach with care partners rather than the individualized patient as the focus. We can't change the progression of dementia, at least not yet, but we can change the carer. This will transform the so-called symptoms that people find so disturbing and fearful. Thank you.
Thank you so much, Danielle. I'm absolutely delighted to have listened again to those wonderful papers that we recorded about a month ago. But before we get going in terms of answering the questions or indeed discussing the papers, I'd like to extend a warm welcome to, Daniela tells me there are 90 people in the auditorium. Thank you so much for coming and listening to us. And I hope that some of you in the audience are Australians, and I hope that some of you are our friends, both our Australian colleagues and our international colleagues. So I'd like to, on this very last afternoon of the conference, to be honest, we were expecting nobody to turn up, which those of us that have had long conference experience know that being put on the last session on the last day is usually the death of your ideas. You don't get an opportunity to discuss a great deal at all. So thank you all very much for being in the audience. And I'd also like to take this opportunity to thank Lucie and Sachin in particular. They were absolutely brilliant papers. I could not have done better myself. Well, I couldn't have done better myself. Absolutely, it would have been impossible. And pay tribute to the two of you, plus, of course, Maisha, Jen, and all the other. I mean, I think off the top of my head, just in the last couple of years, we've had probably, Gaynor and I, we would have been working with probably about 20 students, undergraduates, postgraduates, on-field placement. And I can't tell you how much I have learned from all of you, how much you've stimulated me, and how much I just love these conversations. So I'm really looking forward to involving our audience here, and well, it's obvious how far we've come. So over to you guys. We have, I gather that there are no questions yet in the chat. So perhaps we can use this opportunity to quickly reflect, the four of us, on having watched this, after recording it 6 weeks ago. Would you three be willing or able to make any comments on how it struck the three of you in terms of the way the papers held together, our approach, where the gaps were, how convincing we were? I thought, frankly, just between the four of us and the audience, close your ears for a minute, I thought we were pretty convincing. Anyway, over to you guys, and I'll watch the chat box and see if any more questions come in while we're talking. So, audience, please feel free to become involved. But for the minute, I'll hand it over to the three of you until we get any further questions. Gaynor?
In some ways, I've already said in my own presentation, my responses to the session as a whole. But let me emphasize the one thing that the findings of our kind of combined project keep reinforcing, that dementia is a social experience, and that we really do need the dominant medical models to move over so that we can get very, very good communicative, relationally based orientations to living well with dementia. Yes, some of it may one day be alleviated by pharmacological remedies. But even then, these are about people whose communicative skills are declining, and it is us, the people who surround them, who need to adjust our own communication skills, our own attitudes, in order to hold them in a good life. And I think we have to stop thinking we can't hold people with dementia in a good life, as Lucie pointed out. I don't know whether you want to add anything to that, Lucie.
Yeah, I think it's an important part is sort of looking beyond our sort of normal expectations of what it means to live well, and that some people with dementia have the capacity to live well and fulfilled lives even throughout the progression of the disease. And it's important to maintain that instead of disregarding people because there is no cure.
I think, and of course, that was so well emphasized in Sachin's paper, you know, the way in which people were isolated was probably far more damaging to their dementia than even COVID might have been. Sachin, what would you like to add?
Oh no, just like how like throughout all the papers, I just found like there's still like a heavy reliance on medication and the biomedical model, just in general when it comes to dementia care, and how it's almost seen as like a box to tick off, and in some cases, and I guess it's just like how, like through my experience with dementia reframed, especially just like reframing people's perceptions is like step one, and then how that can lead towards better and positive changes in people's lives as well. It's just
look, that's as I said, Sachin, working with you on this paper has been absolutely fascinating, and of course the three of you are absolutely correct. I mean, you said, you know, that it's like medication and sending people, you know, this is the diagnosis, this is the medication, this is all we can do. It's tick a box. But unfortunately, as we have all pointed out, that's the only box that is ticked by the medical model, within the medical model, by the medical profession. As Gaynor has said so often, medication is obviously, we can use it and we don't use it. We use it really badly here in Australia, appallingly as a matter of fact. And we've got another symposium that we could easily mount on the question of medication. But the most important thing about the most important medicine that we have for people with dementia, and indeed for any of us who are unwell, is good care, good relationships between people, ongoing relationships between people who really care about us and understand our basic humanity. Care is the best medicine, and it is the amount of money, and I'll hand over to Gaynor in a minute because I know this is a really important issue for her. Well, it's for all of us, of course, but the amount of money we spend on pharmaceutical research, it's just, and I think about 10% of dementia research, probably less, is spent looking at how we can actually support both carers and those with dementia at the present moment, those that are already there. We're looking to the future all the time and trying to find a magical pill that'll fix it. Gaynor, I think you can probably sum that up.
Well, I think, yes, and when we say we're critical of the medical model, that's not to say that all of us wouldn't like to find cures for the many different kinds of dementia. Of course, it would be good if we could slow down its progression. Dementia, let's get real, is a nasty terminal disease. But as Jane said, in the meantime, we can't be rushing off people who have dementia, you know, and that is millions and millions of people. And for every one person with dementia, there are going to be at least two care partners supporting them. And we must put more focus on them. Living a quality life with dementia is, and that is the message of the session, of course, all about really good care. And it's relational, communicative care that requires particular skills, very, very learnable, very accessible, but you've got to know. So in some senses, and I think what Sachin has just alluded to, as well as the other presentations, this is about a new vision for dementia care that, you know, it takes us away from that stigma into realization that, yes, we can help people to live well.
Look, thank you all so much for being at this session, particularly my gorgeous colleagues, but also for the audience. I hope that you got a lot, or at least got something out of this presentation. Well done, Sachin. Yes, I think that's absolutely appropriate. But I'd just like to stress that, of course, if we get it right, in the case of people with dementia who at the moment are so excluded, we get it right for everybody. Nearly got there. Timing was a tiny bit off, but close enough. Okay, darlings, look, thank you all so much. Wasn't that, I think that was actually an excellent session. I'm amazed there were 90 people there.
No, 19, I think she said, didn't you?
Oh, 19. I thought she said 90. Damn it. Oh, okay.
I actually thought 19 was pretty good for...
Well, 19's fantastic. I think 19 is, I'm stunned, absolutely delighted. I was expecting absolutely nobody. And of course, Sachin and Lucie, you know, Gaynor and I have had that, I can tell you how many times I've had that experience of going along, travelling 1,000,000 miles to present a paper and 3 people coming to listen to me. And I've realised over my lifetime that the audience in some ways is completely unimportant. It's about getting all your ideas together, getting to the conference and networking and getting involved in those networks. So the presentation, although it's obviously important, is just a way in. And Sachin and Lucie, that's what we're trying to do with you two as well. Go, Sachin.
I think it's still going on for some reason.
Oh, we
Like,
still...
No,
we still
we're not live, but I think like the presentation is still going on the auditorium.
Oh, really?
Yeah,
Oh, okay.
not like the presentation. I think
So they must have pre-recorded and then just stuck it in. How's that working? You're in the room, obviously.
Oh wait, I think all this is recorded.
Oh, look, I'm so pleased you're on side. What would we do without this gorgeous young man? So you're in the auditorium 3 now. So what's happening?
No, I think we're live at the moment.
Right. Okay. Oh, there's something in the chat room. Let me check that. Oh, you're live. Okay. So we're still live. So I can finish what I was saying. What I was starting to say was, if we can get it right, if we can establish a compassionate, caring community where people are kind to each other and look after each other, we are also and include particularly the most socially excluded and those that at the moment are experiencing the most terrible, horrendous conditions, and I'm talking about those with dementia and their carers. If we can make it right for them, if we can create caring, kind, compassionate communities where we all care, we are well on our way to creating what we all want, and that's a caring world for everybody, where everybody across the globe, the culture is to care for people and to challenge the individualistic neoliberal response and just eliminate it. And we are on the edge and the beginning here in Australia of a wonderful we have a wonderful opportunity to do this. I've just been told that I now need to close. Sorry, audience, about that chit-chat in between, but I don't think we said anything that well, I certainly didn't say anything I'd regret. So, look, thank you all very much for coming, and thank you so much for listening to us. And just go off there, and all of us, we just need to keep working away, and we're all together and supporting each other in creating this wonderful, caring world where we're all cared for, we're all kind to each other, and we include the most excluded and indeed first. They're our priority. Thank you all very, very much. And thanks, Sachin, for telling me we're live. Bye-bye, everybody.